Hello, I'm Owen Seddon. I'm one of the consultants in infectious diseases and medical microbiology at Public Health Wales, and I'm going to give you a short talk now on OPAT, friend or foe of antimicrobial stewardship. So for those of you unfamiliar, what is OPAT? Well, it stands for Outpatient Parenteral Antibiotic Therapies. That's intravenous therapy given an outpatient, facilitating administration of IV antibiotics in the community. And that's quite topical at the moment because in Wales it fits with the stated aims of Welsh Government to try and bring health closer to home. And you may have heard of the 6 goals of Wales, and several of these fit under OPAT. So we have the home first approach, optimising hospital discharges, which is another thing OPAT can be used for, clinically safe alternative to admission to hospital, and people can be signposted to the right place first time. So if all they need is IV antibiotics, they can come to us without having to go via emergency care and further clog up our waiting rooms. So quick quiz question to try and get you thinking. So OPAT sounds like it might be a new thing, but it's actually been around a little while. When do you think OPAT was developed? And to make it easier for you, which iteration of share do you think best fits with when OPAT first came around? So we've got 60s, 70s, 80s, 90s, noughties, and 10s share there. Pick which one best fits when you think OPAT was developed. Okay, and the answer is actually 70s share. So OPAT was developed in the 1970s, principally in the cystic fibrosis population in the United States, as a population who were requiring lots of intravenous antibiotics, but could generally ideally be managed outside of the hospital, in particular for both because of risk to them from hospital-acquired infections and because they were generally stable apart from respiratory disease. And there's lots of positives to OPAT. It has very high patient satisfaction. Patients enjoy not being in hospital, unsurprisingly. It saves trusts money compared to a hospital bed. OPAT treatment is undoubtedly cheaper, and it's got comparable or better outcomes for a wide range of infections, as well as reducing the risk to the patient of healthcare-associated infection and other hospital morbidity. It's a double winner, really, because you can both avoid admission in that GPs can refer to the service directly, and we get a large number of referrals for things like skin and soft tissue infections, respiratory tract infections, and also as part of early supported discharge, so getting patients home, perhaps they've been admitted, too unwell to be managed in the community, but once stabilised, if still requiring intravenous therapy, we can get them out of hospital on an OPAT regime. And microbiology obviously have a huge role to play in signposting teams to that service and getting patients out of hospital. And this is just to blow the trumpet for our own service. So up until June 2023, we'd treated just over 700 patients, and we'd saved between 8,500 and 9,000 bed days, which is really powerful data when you're presenting to executives about your service and trying to impress upon them the value of it. What do we treat and how? Well, as I said, we treat a wide range of conditions, but amongst the most common would be skin and soft tissue infections, or SSTI, followed probably by the bronchiectasis and lower respiratory tract infections. But we also treat a range of complex bone and joint infection. We've treated endocarditis, meningitis, intra-abdominal infection, and others. And there are 3 principal modes of delivering OPAT. So for the vast majority will attend our nurse-led clinic, which is down in St David's on Cowbridge Road. Some will self-administer, so potential in very well, especially younger patients, that they can be trained to self-administer their IV antibiotics under supervision. And for a small number of patients, we can also facilitate intravenous antibiotics at home. And around the country, different OPAT services use a mixture of those modalities to provide their service. Some are very much more home IV-led, but the drawback to that is that it's quite a lot of nursing time. Often it'll require 2 nurses to visit a patient's home. And if you're covering a large geographic area, there's no way you can see the same number of patients as you can when patients attend clinic. But obviously for patients to attend clinic, they have to be relatively mobile, they have to have a means of transport. And so most areas will use a mixed model there to best suit their population's needs. So moving on to stewardship, which is supposed to be the focus of the talk. So OPAT, as you know, is part of the start, then focus algorithm. So it's part of the 5 decision points you can make at 48 hours after reviewing antibiotics to try and impress it upon clinicians' minds when they're making these sorts of decisions. So stopping IV to oral switch, changing antibiotics, continuing antibiotics, or OPAT. And it's pivotal to me, really, that I would, even though I'm banging the drum for my OPAT service, I'd much prefer people to be doing many of the other things, so stopping inappropriate antibiotics or oral switching where appropriate, and we'll come on to that a little bit later. So there is a bit of a stewardship OPAT dilemma in that stewardship tells us we need to pick the right drug for the bug. So we need to pick the most narrow spectrum agent in order to treat the infection possible. But that's not always possible in OPAT because we also have to balance the convenience of the dosing and the administration. So if a drug is bolus versus infusion, that increases the time or reduces the time in the case of boluses and means our throughput can be higher. If a drug needs to be given more than twice a day, it's not really convenient for OPAT services, especially if the patient's having to come to you to get it. So what we're really looking at is once daily antibiotics. And that's reflected in our anti-infective use. So as you can see here, ignoring the antifungals at the top, which have a very few episode counts, the 2 biggest drugs we use are ceftriaxone with 360 episodes, and that's primarily for skin and soft tissue infection, and ertapenem. But we are increasingly using piptaz, piperacillin tazobactam, which has 49 counts there, and that is primarily in the bronchiectasis Pseudomonas population, because it's given us a good outpatient option for Pseudomonas, which we didn't necessarily have previously. But unfortunately, those antimicrobials are not particularly narrow spectrum, with the exception perhaps of ticoplanin, and the cephalosporins in particular are known to have a C. diff risk. So are we driving C. diff infection through OPAT? And the good news seems to be that no, we're not. And although cephalosporin use is restricted in hospitals due to a high risk of C. diff infection, despite using them very much in OPAT settings, the UK OPAT cohort study suggests that we actually have much lower rates of C. diff compared to hospitalised patients, and that's almost certainly because the patients are less frail and therefore less at risk. I mentioned that we're using increasing amounts of tazocin, and that's because of the advent of elastomeric pumps. So for those of you who haven't seen those, there's a picture on the left there, but essentially these are balloons which we fill with an infusate of tazocin, and they then, there's no battery or electrical requirement. They contract over 24 hours by use of a spring, and they provide a continuous infusion of the antibiotics. And they are a godsend both in terms of increasing our antimicrobial spectrum, increasing our range of agents that we can use. They help with stewardship in some ways, because some narrow spectrum agents can go through them, in particular I'm thinking of flucloxacillin there. But principally, the majority of the patients we're using these in are getting tazocin, and that's because they have Pseudomonas normally in the context of bronchiectasis. So again, not really helping in the antimicrobial stewardship debate, because they are tazocin is obviously very broad spectrum, although it is the most appropriate antibiotic for the bug in that case. And a note of caution, therefore, about an OPAT is that we do have to gatekeep it. So OPAT is not an alternative to source control, is what I'll often impress upon people. So in particular, undrained abscesses, where there is a decision about surgery to drain the abscess versus a long course of antibiotics. And I think if OPAT is available and is an easy choice, then you have to be very careful that you're not using it as an alternative to source control. It's not necessarily better than oral antibiotics, and I'll say a little bit about that in the next slide. But the key thing, I think, as we all know, is that making antibiotics easy to give doesn't always promote good behaviour, and you have to be careful when you're providing a service like this, which is convenient, that you're not encouraging over-prescribing of antibiotics or antibiotics where they're not necessary. And the other thing about OPAT is that the patients require a line, and as this data shows, the line is actually potentially in some cases more dangerous for the patient than the drug, in that you can have catheter-associated infections, phlebitis, clots, etc. So I said OPAT is not an alternative to oral antibiotics. Two big trials in the last decade, really, which have changed the paradigm of IV antibiotics for deep-seated infections. The first one is POET, partial oral versus intravenous antibiotic treatment of endocarditis, which showed that you can have equivalent outcomes with oral antibiotics versus IV antibiotics in left-sided endocarditis. A few caveats to the study, but this has very much come into practice now. And we treat endocarditis with oral antibiotics. And the second was Aviva, including Harriet Hughes, who's one of my colleagues in Cardiff, the oral versus IV antibiotics for bone and joint infection study, which showed that patients treated for 6 weeks with IV versus oral antibiotics had similar outcomes at 1 year. And this was for a huge range of different orthopedic infections, including prosthetic infections, osteomyelitis, septic arthritis, etc. Both groups had adverse events, but they both occurred at a similar rate. And essentially, again, this has changed practice pretty dramatically, and the majority of bone and joint infections will now be managed with oral antibiotics where a sensitive option exists. So I think I've made the case there that OPAT is bad for antimicrobial stewardship because we're giving lots of broad spectrum antibiotics. We're promoting poor prescribing choices because we're making it very easy for people to give antibiotics for a long course, and we're possibly discouraging people from doing an intravenous to oral switch. But I do think that there are some good points to OPAT. Obviously, otherwise I wouldn't be doing it. And the main reason OPAT is good for antimicrobial stewardship is that we have an infection MDT approach, which means that we can select the most appropriate antibiotic. And our principal impact on antimicrobial stewardship is that we stop antibiotics and we shorten duration, as well as getting people into the community where they're less likely to pick up drug-resistant infections. So I mentioned gatekeeping. So prior to 2018, in Cardiff at least, the mechanism for OPAT was that the clinical team or GP could refer to the acute response team, who are a team of nurses, specifying an antibiotic and a duration, and then the acute response team would administer those antibiotics. But there were some problems with that plan because the original clinical team were often not available for review. It was quite a passive process, and it was quite poor stewardship in that the nursing team had no control over the duration of antibiotics, and if the patient got better, they continued on the course until the specified stop date of the clinical team. So how it was redesigned was that the clinical team or the GP would refer to the acute response team, but then infectious diseases and microbiology will then take over that patient, and we will see them physically once a week, as well as the nurses seeing them every day, and we're available to answer clinical questions. We also have a clinical pharmacist who sees patients on a second point during the week. So we have two sort of decision points, really, and we have regular MDTs and step downs in collaboration with the referring team if appropriate. And that means that we can keep a much closer eye on what these patients are doing. We can convert IV to oral switches. We can stop antibiotics if we don't feel they're appropriate, and we can gatekeep much more what goes into the service. And the best way to demonstrate that really is in this data around skin and soft tissue infections. So what you can see here is that the median duration of OPAT for skin and soft tissue infections declined pretty dramatically. This is Scottish data, but we can also replicate it in Cardiff. So going from an initial longer than 6 days and sometimes up to nearly a fortnight, the mean duration of IV antibiotics now for cellulitis in Cardiff is under 72 hours with an early oral switch. And these are, of course, patients who've already failed on oral. So they're patients where they've normally had some oral fluclox, been referred to the service because that's not working. The expectation might be that they would then need a prolonged course of IVs, but actually we can give a short course of IVs and convert them very quickly back to orals once they're improving. So in summary, there's no real data on whether OPAT drives antimicrobial resistance that I've been able to find, but it would be interesting to see the effect of these broad spectrum antibiotics on the patient's gut microbiota. We don't seem to be increasing the risk of C. diff. We're possibly promoting poor antibiotic prescribing, but our counter argument to that is that there's rigorous review of these patients and gatekeeping to try and ensure that they're on the right antibiotics, and that if they don't require antibiotics, they are stopped. And essentially the message here is that a good infection MDT approach can reduce antimicrobial use and promote good antimicrobial stewardship, as well as getting the patients closer to home and fulfilling the Welsh Government's 6 goals priorities. Thank you very much for listening.